Welcome back to the deep dive. Today, we are undertaking a mission that is, well, absolutely critical for anyone heading into the operating theater or, facing an anesthesia board exam.
That's right.
You, the MD candidate, have given us the source material, and we are treating this deep dive like a high-stakes, high-yield prep session. We're going to take the fundamentals of regional anesthesia, specifically spinal anesthesia, and make sure you don't just know the facts.
Right. You need to understand the clinical logic behind every single decision.
Exactly.
Our goal is to move way past rote memorization. I mean, on the surface, spinal anesthesia seems deceptively simple. Inject a drug, achieve a block, but the complexities, the anatomy, the fluid dynamics, the physiology of a potential collapse, that's where examiners in real clinical scenarios are going to challenge you.
So we're building the mental models today.
We're building robust, structured cause-effect chains. If you understand why the block behaves the way it does, you can manage any outcome.
Okay, let's unpack this and anchor ourselves right at the beginning. A precise definition and where this procedure even comes from.
Absolutely. For an examiner, a precise definition shows you have attention to detail. So spinal anesthesia, or SA, is the injection of a local anesthetic drug and, often an adjuvant directly into the cerebrospinal fluid.
The CSF.
The CSF, right inside the subarachnoid space. And this results in anesthesia, analgesia, and muscle relaxation, primarily affecting the lower extremities and the torso.
The injection site is the key detail there. The subarachnobility space. It's what makes it different from, say, an epidural.
Exactly.
And while it feels incredibly modern, this idea of localized surgical pain relief is, well, it's ancient.
It is indeed. While the specifics of modern SA were really developed in the late 19th century, the concept has these ancient roots. You can think about the early attempts at surgical analgesia using things like opium poppy.
Small meat.
Containing morphine, yes. And mandrake root, which has anticholinergic compounds. But these were crude, systemic methods aimed at just general sedation and pain relief.
So when did we make that leap from knocking the patient out to a targeted neuraxial block?
The modern story really begins with James Leonard Corning in 1885. He was experimenting with cocaine injected near the spinal cord, though he was probably in the epidural space.
Ah, okay.
But the first true clinical application of a subarachnoid injection is credited to August Beer in 1898. And this was just a revolution. For the first time, you could get profound surgical anesthesia without rendering the patient unconscious.
Which eliminated so many of the risks from those early general anesthetics like ether.
The massive systemic risks, yes.
And the evolution didn't stop there. Early SA was just a single shot, right?
Yeah.
What were the big innovations that expanded its use?
Well, the drive was always towards more control. So key landmarks include the introduction of continuous spinal anesthesia techniques. You had Lemon in 1940 and then Tuho in 1944. These techniques allowed you to titrate the dose and prolong the effect by leaving a tiny catheter in the subarachnoid space.
But we don't really do that anymore, do we?
No, and we have to note that high-concentration continuous spinal anesthesia later became associated with catastrophic neurological complications, which is why the technique is very rarely used now. It's been replaced by the combined spinal epidural approach.
Right, and here's what I think is the most compelling modern context for this. It's specialized application. I think a lot of people assume SA is just for, orthopedics or obstetrics.
Yeah.
But why would an anesthesiologist risk a sympathetic block in, say, a really high-risk cardiac patient?
That is a classic clinical pearl that shows true understanding. The use of SA, especially with opioid adjuvants, has extended into these high-risk areas like cardiac surgery, which was first reported back in 1980.
So why? What's the logic?
The why is simple. SA provides a very effective sympathetic blockade. And this significantly decreases systemic vascular resistance, and crucially, it reduces myocardial oxygen requirements because you're lowering the heart rate and the blood pressure. So for a patient with poor cardiac reserve, a controlled regional block can actually be physiologically safer than the huge hemodynamic swings and stress response from general anesthesia and intubation.
So you're not just avoiding GA, you're actually using the sympathectomy as a therapeutic tool. That is the critical insight.
That's it.
All right, let's move on to the architecture. The anatomy has to be crystal clear.
It does. Before we even think about touching a nerve, we have to visualize the journey. In Aviva, you need to be able to describe these surface landmarks with total confidence.
Okay, let's nail these Viva Gold points then. Where do we start?
Let's start superiorly. The C7 spinous process, the vertebra prominence, that's your most prominent cervical landmark. Then moving down, the inferior angle of the scapula is a useful, if a little less precise, guide. It generally corresponds to about the T7 vertebral body level.
So that helps you frame the thoracic spine.
Exactly. And for the injection site itself, the gold standard is the L4-L5 interspace. So how do we find that reliably?
Tuffier's line.
Tuffier's line, or the intercrystal line. It's the line you draw between the highest palpable points of the iliac crests. It almost universally crosses the L4 vertebral body, or ideally that L4-L5 interspace.
And the reason that's the preferred spot is critical, right?
It's critical. It is reliably below the termination of the adult spinal cord, which minimizes your risk of direct trauma.
Okay, and finally, the boundary for the fluid sac itself.
You look posteriorly for the posterior superior iliac spine, the PSIS. A line connecting them approximates the S2 posterior foramina, and that's the typical endpoint of the dural sac. Knowing S2 is vital for understanding the block's potential extent and for complications like PDPH.
Right, which is all about the CSF leak from that dural sac.
Precisely.
Now, let's get into the critical developmental differences. This feels like a classic exam trap, differentiating a safe practitioner from a reckless one. Adults versus pediatrics.
It is a huge trap. The primary difference is the termination point of the spinal cord, the conus medullaris. In an adult, the cord ends at the lower border of L1, maybe L1, L2, so any puncture above L3 is potentially very hazardous.
And in children, it's much lower.
Much lower. In neonates and infants, the cord is significantly longer and terminates way down, around L3 or even L4 at birth. It doesn't fully ascend to that adult L1 level until about age 20.
And the dural sac, too.
Same story. The dural sac termination is lower in children, often down to S3 or S4, compared to the adult S2 level. The take-home message is, if you attempt an L3, L4 puncture in a newborn, you risk direct spinal cord trauma. You have to go lower.
L4, L5, or L5, S1?
Exactly.
Okay, let's move to the path of the needle. Can you walk us through that step-by-step layer sequence from the skin inwards for a standard midline approach?
This has to flow off the tongue without any hesitation. First, skin.
Skin.
Then subcutaneous tissue, or fat. Third is the supraspinous ligament.
Connecting the tips of the spinous processes.
Correct. Then the interspinous ligament, filling the gap between them. Then you hit the ligamentum flavum, the LF. This is the dense, elastic yellow ligament that gives you that tactile pop of resistance.
That's the first pop you feel.
Often, yes. Then you're in the epidural space, which contains fat and the venous plexus. Then you hit the duramater. And finally, you're in the subarachnoid space, where the CSF and spinal nerves are.
So that ligamentum flavum and then the dura, those are the two key feelings. Once we're in the subarachnoid space, we're dealing with CSF. Let's quantify this environment.
The total adult CSF volume is roughly 100 to 150 millimalt. But, and here's the crucial detail for spinal anesthesia spread, the volume we're actually injecting into the spinal subarachnoid volume is much smaller.
Right.
It's only about 20% of the total, so maybe 30 to 80 millimalt, primarily from about T11, T12 downwards.
And that small volume explains why tiny changes in dose can have such massive effects. How quickly is this fluid regenerated?
Very quickly. The production rate is astounding. It's about 500 millimol per day, or about 0.35 milliliters per minute. The entire volume turns over 3 to 4 times a day. This production is mainly from the choroid plexus, and it's an active process. It depends on cerebral perfusion pressure.
So if your CPP drops too low, say below 70, production slows down.
It slows right down.
So we have this constant pressure, constant turnover. Where does it all go?
Well, the flow is helped by arterial pulsations and ciliary movements. It moves through the ventricles and exits into the subarachnoid space. And then absorption is primarily through the arachnoid granulations that project into the dural venous sinuses.
That's about 90% of it.
About 90%. The rest is absorbed via spinal arachnoid villi and perineural lymphatics. And this whole absorption system is passive. It's driven by the pressure gradient between the CSF and the venous blood.
And that brings us to pressure. What's the normal range, and why is that clinically relevant?
The normal pressure, if you measure it in the lateral decubitus position, is about 130 millimeters of water, with a range of maybe 70 to 180. Clinically, measuring that opening pressure helps diagnose things like idiopathic intracranial hypertension, or, it confirms the low pressure state you see after a CSF leak.
Which is the mechanism of the post-dural puncture headache.
Exactly. It's that dynamic balance of production and absorption that we are interrupting when we puncture the dura.
Okay, let's transition from this static anatomy to the dynamic physiological event. We inject a tiny volume of local anesthetic. What happens at the cellular level?
Right. So we have to understand the mechanism of the nerve blockade. Local anesthetics are weak bases. They cross the nerve sheath in their non-ionized form, and then they reionize inside the nerve cell. Their main action is binding to the inside of the voltage-gated sodium channels in the nerve membrane.
So they're essentially stabilizing the channel, locking it shut.
Exactly. They prevent the channels from opening, they stop the sodium influx, and that stops the action potential from propagating. This happens right along the nerve root itself, blocking both the posterior efferent sensory fibers and the anterior efferent motor and autonomic fibers.
And you need to reach a critical concentration for that to happen.
You do. You need to achieve what's known as the CM, or critical blocking concentration, right at the site of the nerve fibers.
Okay, this brings us to what is maybe the most defining feature of an neuraxial block: differential blockade. Why is it that the patient loses the ability to feel cold before they lose the ability to move their toes?
Differential block is a very high-yield concept because it forces you to synthesize your anatomy and pharmacology. It just means that a complete block of one modality, say the sympathetic system, happens at a lower LA concentration than what's needed for the sensory or motor systems.
Walk us through that order of sensitivity. Why is there a difference?
Yes. It's purely related to fiber diameter and myelination. The local anesthetics block smaller and myelinated fibers most easily. So the progression of the blockade from most sensitive to least goes like this. First, the preganglionic sympathetic B fibers.
Smallest and myelinated.
Right, they have the lowest critical blocking concentration. Then the A delta fibers for sharp pain and temperature. Then A gamma. Then A beta for light touch. Then A alpha for motor and proprioception. And last, the C fibers, which are small but unmyelinated, for dull pain.
So that order dictates the functional loss. Temperature, then proprioception, motor, sharp pain, and finally, light touch. But we also see a difference in the segmental height of the block.
This is the other crucial point. Clinically, the sympathetic block is routinely found 2 to 4 dermatomal segments higher, more cephalid, than the sensory block, which is, in turn, several segments higher than the motor block. And this is because the sympathetic fibers, when they exit, travel a bit further within the CSF before they're protected by the connective tissue sheaths of the spinal nerves. This makes them more accessible to the LA solution for a longer distance.
So that structural difference means the concentration gradient just hits those sympathetic fibers over a broader, more vulnerable area. Okay, let's tackle the most immediate risk we face, the hemodynamic effects. Give us the full cause-effect chain for hypotension.
Okay, hypotension is a direct consequence of the sympathetic outflow blockade. First, the block site. The neuraxial block interrupts sympathetic preganglionic fibers that come from the thoracolumbar segments, mainly T5 to L1.
And these fibers control the smooth muscle in the arteries and veins.
Crucially, the venules. When these fibers are blocked, you lose sympathetic tone. This causes arterial vasodilation, which decreases your SVR, and massive venous dilation. The venules dilate maximally because they rely almost entirely on sympathetic input for their basal tone.
So all the blood just pools.
Profound blood pooling in the visceral circulation and the lower extremities. It's like a functional autotransfusion out of the central circulation. And the hemodynamic consequence is clear. Decreased venous return leads to decreased ventricular filling, which means decreased stroke volume, then decreased cardiac output, and finally hypotension.
So spinal anesthesia causes a preload crisis, not a pump failure, unless the block goes too high.
Precisely. And that brings us to bradycardia. If the block ascends and reaches the upper thoracic region, specifically T1 through T4, we interrupt the cardiac accelerator fibers.
These are the sympathetic fibers that maintain heart rate and contractility.
Right. So if you lose that sympathetic input, you're left with
Unopposed vagal tone.
Correct. Unopposed vagal tone. This causes severe bradycardia and further depresses cardiac output, creating a hemodynamic disaster. And what's more, the combination of severely decreased venous return can trigger the Bezold-Jarisch reflex.
Right, the paradoxical reflex.
Yeah, it's mediated by mechanoreceptors in the ventricular walls that sense the near-empty ventricle. They signal the brainstem to increase vagal output, leading to even more severe bradycardia and profound vasodilation. It can even culminate in sudden cardiac arrest if it's not treated immediately.
That is a highly structured explanation. Hypotension is T5L1 pooling. Bradycardia is T1-T4 denervation plus that Bezold-Jarisch reflex. Let's move to the respiratory effects.
Fortunately, the respiratory system is pretty robust, mainly because the diaphragm is spared. The phrenic nerve is innervated primarily by C4. So unless you induce a very rare total spinal block that goes all the way up to C4, which is often fatal, the patient maintains their primary ventilation.
What function is impaired with a high thoracic block then?
A high thoracic block will paralyze the intercostal muscles and, if it's high enough, the accessory muscles. This primarily impairs forced expiration,
So, coughing.
coughing, and the ability to take a deep, sighing breath. While their minute ventilation might be adequate, the patient's ability to clear secretions is diminished. But their protective laryngeal reflexes, unlike with general anesthesia, are usually preserved.
Okay, and quickly, what about the effects on other critical systems? CNS, GI, and renal.
For the CNS, if the block ascends to the cervical region, you get a high spinal, which leads to widespread CNS depression, loss of consciousness, and eventual respiratory paralysis. The GI tract, on the other hand, often benefits. The sympathectomy leaves the parasympathetic system unopposed, which speeds up gut motility.
So a quicker return to eating.
Exactly. And for the renal system, blood flow is generally maintained through autoregulation, as long as the mean arterial pressure doesn't drop below, say, 60 or 70. But severe, prolonged hypotension is a major risk for acute kidney injury.
All right, now that we've got the anatomy and the physiology down, we have to talk about the agents we're actually using. Let's start with the current standard long-acting choice, bupivacaine.
Bupivacaine is a highly potent, long-acting aminoamide local anesthetic. Clinically, we use two main forms in the subarachnoid space. Hyperbaric, which is typically a 0.75% solution with dextrose to make it denser, or isobaric plain, usually 0.5%.
And what are its key pharmacological features?
Well, it has high lipid solubility, which increases its potency, and very high protein binding, 90 to 95%, which is good because it limits its ability to cross the placenta in obstetrics.
Okay, let's talk about its major liability. Cardiotoxicity. Why is it so much more dangerous than, say, lidocaine?
This is a critical mechanism for the exam. Bupivacaine is what we call a fast-in, slow-out agent at the cardiac sodium channels. It binds tightly and quickly during depolarization, but, and this is the key, it dissociates very slowly during diastole.
So it accumulates.
It accumulates, causing progressive cardiac conduction depression, leading to refractory arrhythmias like VT or VFib that are notoriously difficult to resuscitate. The drug essentially poisons the cardiac conducting system. This extreme risk led to its contraindication in high-volume epidural blocks, though the risk in a single-shot spinal is theoretical because the dose is so tiny.
And levobupivacaine is the attempt to fix that.
Yes, levobupivacaine is the pure S-enantiomer of the racemic bupivacaine. It offers pretty much equivalent potency, but with significantly less cardiotoxicity and neurotoxicity. It's structurally safer, which is why it's replaced the racemic mixture in many continuous techniques.
Okay, moving to lignocaine, or lidocaine. Our sources say it's largely obsolete for routine spinal anesthesia. Why did the standards shift away from such a common drug?
The main reason is the risk of transient neurologic symptoms, or TNS. While lidocaine provides excellent surgical anesthesia, its use for spinal, especially at concentrations over 5% or doses above 60 milligrams, is highly associated with a higher incidence of TNS.
Which is that severe transient pain in the buttocks and legs after the block resolves.
Exactly. It's benign and it resolves on its own, but the distress and the potential for diagnostic confusion just made the clinical community pivot towards agents with a better safety profile.
And what about ropivacaine?
Ropivacaine is also an aminomycin, structurally similar to bupivacaine. It's a bit less potent, but it has a better safety margin for cardiotoxicity. Clinically, ropivacaine tends to produce less motor block at equivalent concentrations, so it's often chosen for spinals where you want a rapid recovery of motor function.
All right, let's discuss the physics that we use to control the outcome. Baricity.
Yeah.
This is probably the most important controllable factor for the practitioner. Can you define it precisely?
Baricity is the ratio of the density of the local anesthetic solution to the density of the cerebrospinal fluid at body temperature. CSF density is about 1.003 gml. So a hyperbaric solution is denser than CSF, that's bupivacaine with dextrose, it sinks.
And hypobaric is less dense. It rises.
Right. Bupivacaine diluted with sterile water, for example. And isobaric is about the same density as CSF, so its spread is mostly independent of gravity.
So baricity is the key to gravitational control. How is this used in practice?
It allows you to actively manipulate the block height by positioning the patient. If you inject a hyperbaric solution with the patient in a slight Trendelenburg, the solution pulls cephalid, giving you a higher block. If you use a hyperbaric solution, a reverse Trendelenburg will make it rise.
So you can sculpt the block for specific surgical targets.
Precisely. For perineal surgery, you might keep the patient seated briefly. For upper abdominal procedures needing a high block, you position them accordingly. It's crucial.
I recall a clinical pearl about temperature influencing baricity. Is that practically significant?
It's theoretically relevant. Warming an LA solution makes it less dense, so more hyperbaric. But while some practitioners believe warming it slightly can promote a small initial cephalad spread, the solution equilibrates with CSF temperature so quickly that baricity itself remains the main driver.
Okay. Finally, let's turn to adjuvants, which enhance the block. Let's compare the two primary opioid classes used intrathecally.
We separate them by their lipid solubility, which really dictates their effects and side effects. First, you have the highly lipid-soluble opioids like fentanyl or sufentanil.
Right.
They cross neural membranes rapidly, they give you a fast onset of analgesia, they enhance the block's intensity, and they're great at decreasing visceral stimulation. But because they're taken up systemically so quickly, they have a short duration of action and cause early immediate side effects like nausea or itching.
And on the other end, the hydrophilic opioids like morphine.
Exactly. Preservative-free morphine. Being water-soluble, it stays in the CSF for much longer. It provides prolonged, excellent post-operative analgesia lasting 18 to 24 hours. The critical risk here is delayed respiratory depression, peaking around 6 to 12 hours post-injection as the drug slowly migrates cephalad.
Which means you absolutely need extended post-operative monitoring.
Mandatory.
And beyond opioids, what about non-opioid adjuvants?
Clonidine is often used. It's an alpha-2 adrenergic agonist that works synergistically to prolong both the sensory and motor block. Its main risk is increased sedation and potentially exaggerated hypotension and bradycardia. Dexmedetomidine is a more selective alpha-2 agonist that's also being studied. It gives great sedation and analgesia with fewer respiratory effects than opioids, but it also significantly increases the risk of hypotension and profound bradycardia.
So using adjuvants is always a trade-off. Better block quality versus managing more side effects.
It's always a balance.
Right, anesthesia is a practical discipline. So let's talk technique. You have to be able to do this safely, starting with clear decision points. What are the primary indications?
Really, any procedure below the diaphragm, especially lower abdomen, pelvis, or lower extremities, where you need sensory anesthesia and muscle relaxation. Often the main reason is to avoid the risks of general anesthesia, particularly in patients with significant respiratory problems or a difficult airway.
Okay, now for the non-negotiable list, the absolute contraindications.
This list is paramount for patient safety. Number 1, patient refusal. Never override their autonomy.
Never.
2, infection at the puncture site. You risk causing meningitis or a spinal abscess. 3, uncorrected severe hypovolemia or hypertension. The sympathetic block will cause circulatory collapse.
Right.
4, bleeding diathesis or therapeutic anticoagulant therapy. The risk of a spinal hematoma is just too high. And 5, markedly raised intracranial pressure. A dural puncture could lead to fatal brain herniation.
And what about the more subtle relative contraindications?
These require more clinical judgment. They include an uncooperative or severely agitated patient, severe vertebral abnormalities like kyphosis that make access hard and spread unpredictable, and existing progressive neurological deficits.
Before the needle even comes out of the packet, what is the required preoperative assessment focus?
Beyond the standard assessment, you have to drill down on 2 areas. First, cardiovascular status, history of cardiac surgery, severe valve disease, pacemaker dependence. We have to know how they will tolerate a sudden drop in SVR and heart rate.
And second,
neurological status. Document any pre-existing deficits meticulously. Any new post-op deficit, even if it's unrelated to the block, could be attributed to the spinal.
okay, how do we optimize the anatomy? Patient positioning is critical.
Maximizing that intervertebral space is the entire game. The patient needs to be maximally flexed, the fetal position, either lying on their side or sitting up. In the lateral position, you have to ensure the shoulders and hips are vertical and perpendicular to the bed. Any rotation can distort the midline and lead to a deviated needle and a unilateral block.
The need for aseptic precautions is just, well, it can't be overstated.
It's strict sterile technique or nothing. Meticulous skin prep is necessary. A critical note for the exam is the risk with skin antiseptics like chlorhexidine solutions. They are neurotoxic if they touch the neuraxis. You have to make sure the prep solution is fully dry and hasn't pooled near the puncture site.
Okay, let's talk needle types. Why has the profession moved so emphatically toward pencil point needles?
The difference is directly tied to the risk of post-dural puncture headache, PDPH. The older cutting needles, like the Quink, have a sharp, beveled edge that actually cuts the dural fibers, leaving a permanent hole.
which means a higher chance of a CSF leak.
A much higher incidence of PDPH. The pencil point needles, like the Whitaker or Sprott, are recommended because they have a blunt, non-cutting tip. They separate and push aside the dural fibers instead of cutting them. The elastic fibers can then fall back into place, which significantly decreases the rate of CSF leak and dramatically reduces the incidence of PDPH.
So once we have the right needle, how do we confirm we're in the right place?
We target the L3-L4 or L4-L5 interspace. The needle angle is typically slightly cephalid, and confirmation of CSF is achieved when you remove the stylet and you see a free, clear flow of CSF back through the needle hub. That's your confirmation.
And the injection itself. Any critical details?
Use only preservative-free solutions. The injection should be slow and smooth, allowing the solution to mix gently with the CSF. A rapid, forceful injection could theoretically cause more turbulence and unpredictable spread, but really, baricity and CSF volume are the main factors.
And the final act, positioning after injection.
This step is absolutely critical, especially with hyperbaric solutions. Immediate patient positioning is how you control the cephalid spread. If you used a hyperbaric solution and need a low sacral block, you might keep the patient sitting up for a minute. If you need a T4 block for a C-section, you immediately place them supine, maybe with a slight Trendelenburg, to pull the solution up into the thoracic spine.
Okay, this is a big one for exams.
Yeah.
The factors affecting spread of a spinal block.
This is what separates those who practice by reflex from those who practice scientifically. You have to know the exam goal point. CSF volume is the single most significant determinant of peak block height. It accounts for up to 80% of the variability.
And it's an inverse relationship.
It's inversely proportional. Less CSF volume means more drug concentration per volume, which leads to greater spread.
So let's break down the variables influencing this, starting with the drug factors.
As we established, baricity is the most important controllable factor. It dictates the gravitational influence. Beyond that, obviously the dose, concentration, and volume of what you inject are important. Higher doses deliver more molecules to the nerve roots, increasing the magnitude and spread.
Now, for the high-yield patient factors that decrease CSF volume and therefore increase spread.
These are all related to increased intra-abdominal pressure, or IAP. Think of a term parturient, a pregnant patient. The gravid uterus markedly increases IAP.
Or a patient with ascites, or a large abdominal tumor.
Same mechanism. The increased IAP compresses the epidural space and causes the epidural veins to become engorged. These swollen veins take up space in the vertebral canal, effectively displacing and decreasing the CSF volume. This is why you must reduce the dose, often by a third, in a term parturient to prevent a dangerously high block.
What other patient variables play a role?
Age is a major factor. Elderly patients need reduced LA doses because they have an age-related decrease in CSF volume. Spinal curvature is also critical. Severe kyphosis can create unpredictable settlement patterns and can also decrease the effective CSF volume, making block levels erratic.
So we've established that things like height and weight are often cited, but they don't really correlate with spread. Is that true?
That is the myth versus reality distinction you need to make in an exam. Standard measures like height and weight, or BMI, do not reliably correlate with the height of the block. But if an examiner asks for the single most important factor, you state CSF volume.
Let's synthesize the technique-related factors. They seem to be all about leveraging baricity.
Absolutely. The site of injection dictates your starting point. And most importantly, the immediate patient position post-injection. We use positioning to take advantage of baricity. For instance, in the supine position, the spine has a trough around T5, T7. A hyperbaric solution will naturally pool there, often leading to a block that peaks in the mid-thoracic region.
And the myth we busted earlier, speed of injection.
While rapid injection might slightly increase turbulence, clinical science validates that baricity, CSF volume, and patient positioning are the primary predictable determinants of block height. Do not rely on injection speed to control spread.
Okay, as future practitioners, our primary job is safety. We have to handle complications systematically. Let's start with the most common acute pair, hypotension and bradycardia.
Right. So, cause and mechanism. We've covered the T5L1 sympathetic block, causing venous pooling and decreased cardiac output, which leads to hypotension. Bradycardia comes from the T1-T4 cardiac accelerator fiber block and the Bezold-Jarisch reflex.
What about prevention? This is where the debate is, right? Fluid preloading versus vasopressor prophylaxis.
Prophylaxis is controversial. Aggressive fluid loading with crystalloids is often ineffective because the venodilation just causes the fluid to pool peripherally. Current consensus leans towards cautious fluid management and prophylactic use of vasopressors, usually a phenylephrine infusion, to maintain SVR and MAP.
And management.
Aggressive management is required. Use potent vasopressors. Phenylephrine is a pure alpha agonist, great for raising SVR. Ephedrine is a mixed alpha-beta agonist, useful if bradycardia is also present. And you give fluids at the same time. If bradycardia is profound, say less than 40 beats per minute, treat immediately with atropine or epinephrine.
Next, the most dangerous scenario. A high spinal or total spinal?
Cause and mechanism. This is from excessive cephalid spread of DLA, often due to a drug misplacement like an accidental large intrathecal dose meant for an epidural or a massive reduction in CSF volume. This leads to complete sympathetic, sensory, and motor block up to the cervical segments. The patient becomes hypotensive, apneic, and unconscious.
In the management.
It's a life-threatening emergency. 1. Airway and breathing. Immediate, definitive airway management. Intubation and mechanical ventilation. 2. Circulation. Aggressive hemodynamic support with massive fluids and high-dose vasopressors like epinephrine to counteract the complete sympathectomy.
The most common post-procedure complaint, post-dural puncture headache.
Cause and mechanism. This is a low-pressure headache. The dural puncture creates a persistent leak of CSF that exceeds the production rate. The loss of fluid volume causes intracranial hypotension. When the patient sits up, the brain sags, pulling on pain-sensitive meningeal and vascular structures.
And the classic presentation is that it's postural.
Exquisitely postural. It gets dramatically worse within minutes of sitting or standing and is relieved by lying flat.
So prevention and management.
Prevention is mandatory. Use small gauge, pencil point needles. Management starts conservatively. Hydration, bed rest, simple analgesics, and high-dose caffeine. If the headache is debilitating and persists past 24 to 48 hours, the definitive treatment is an epidural blood patch.
Where you inject the patient's own blood into the epidural space to seal the tear.
Exactly. About 15-20 milliliters of autologous blood.
Let's differentiate between the transient and the permanent neurological injuries, starting with transient neurological symptoms, TNS.
TNS is pain in the buttocks, legs, or lower back that happens after the block has fully worn off. The pain can be severe, but it's benign. It resolves on its own. Its exact cause is unknown, but it is highly associated with high concentrations of lidocaine.
So prevention is just avoid high concentration lidocaine.
Pretty much.
And the catastrophic cauda equina syndrome, CES.
This is permanent, devastating neurological injury. It involves multiple nerve root deficits, resulting in permanent bowel and bladder dysfunction, motor deficits, and saddle anesthesia. This was tragically linked to continuous spinal techniques using high concentrations of things like 5% hyperbaric lidocaine. Prevention requires strict adherence to appropriate dosing and concentrations.
Finally, the risks of infection and hematoma.
Infection, like an abscess or meningitis, is always caused by a breach in aseptic technique or doing a block on a bacteremic patient. Prevention is strict sterility. A hematoma is caused by bleeding into that confined neuraxial space. Prevention is meticulous screening for coagulopathy. The guidelines for stopping and starting anticoagulants are non-negotiable.
Okay, it happens. The block fails, either completely or partially. We need a systematic approach. What are the common reasons for a failed spinal?
Examiners want you to categorize this. 1. Technical failure. This is the most common. The needle was just not in the subarachnoid space. This can be a true miss or an inadvertent subdural injection where the needle tip is between the dura and the arachnoid mater.
And that gives you a patchy delayed block.
Right. 2. Pharmacological failure. You misidentified the drug, used the wrong concentration, something like that. And 3. Anatomical failure. The patient has an unexpectedly large CSF volume, so the standard dose is subtherapeutic.
How do you recognize failure quickly?
By careful assessment of both sensory and motor function. You test the sensory block with temperature or pinprick. You assess the motor block with the Bromage scale. If the sensory block is too low or patchy or motor function persists, you have a failed block.
And the immediate management sequence.
Time is critical. First, you confirm and wait a bit. Maybe reposition the patient if Baricity could help. If it's a total failure, you assess the dose you already gave. If it was low, you might consider a repeat attempt.
But it's not.
If the dose is borderline or the patient's unstable, you convert. If you used a combined spinal epidural, you can use the epidural catheter. If not, you must transition immediately to general anesthesia, secure the airway, and monitor for interactions between the agents.
So the best offense is a good defense. What are the key prevention strategies?
Accurate technique and planning. Using ultrasound to identify the midline and estimate depth is increasingly common, especially in difficult anatomy. And always, always check the LA vial 3 times for dose, concentration, and baricity right before you inject.
Okay, let's talk about special situations. You have to tailor the block to the patient. Let's start with the classic, spinal anesthesia in obstetrics for a C-section.
We covered the physiology. The gravid uterus increases IAP and decreases CSF volume. The key modification is a mandatory LA dose reduction, typically by about 1/3 compared to a non-pregnant patient.
And you're aiming for a high block.
A high block. We commonly use low-dose hyperbaric bupivacaine, say 10 to 15 milligrams, plus an opioid like fentanyl. The target sensory block needs to be high, ideally T4 to T6, to cover the visceral pain from peritoneal traction.
How does this differ when you're managing an elderly patient?
The elderly also need a reduced LA dose, mainly due to that age-related decrease in CSF volume. Physiologically, their cardiovascular reserve is reduced, and their compensatory reflexes are blunted. They can get exaggerated hypotension. Careful titration and aggressive hemodynamic management are crucial.
What about SA in patients with existing cardiac disease?
This is a nuanced area. For patients with coronary artery disease, SA is often preferred because the controlled sympathectomy decreases myocardial workload. But patients who rely on heart rate to maintain cardiac output, like those with severe aortic stenosis, may not tolerate the bradycardia from a T1, T4 block.
So you have to be very careful.
Very careful. You use low doses, minimize the block height, and proactively use vasopressors to maintain their preload and MAP.
And the patient who tolerates SA the worst, the hypovolemic patient.
This is a scenario where SA is a relative contraindication, bordering on absolute if the hypovolemia is severe. The mechanism is maximal venodilation and pooling. In a patient who is already volume depleted, this sudden pooling leads to a catastrophic decrease in venous return and cardiac output. You have to resuscitate first.
Okay, finally, let's quickly differentiate the 3 main neuraxial techniques for a short note question.
Okay, the comparison centers on where the drug goes, how much, and the result. Spinal anesthesia is in the subarachnoid space. It's a small dose, small volume, with a fast, dense onset and a high risk of headache.
Right.
Epidural anesthesia is in the epidural space. It's a large volume with a slower onset, a less dense block, and a low headache risk, but a higher risk of systemic toxicity.
And the combined spinal epidural, or CSE?
The CSE is the modern solution for complex cases. It combines the rapid, dense onset of a spinal with the ability to provide continuous titratable analgesia through an epidural catheter that you place at the same time.
Okay. We've established the architecture and the mechanisms. Let's consolidate this into the precise format that examiners demand.
For a written theory paper, you have to be ready for detailed, multi-part questions. You'll get asked about baricity and spread. You'll need to define it, describe its relevance, and list all the factors affecting spread, focusing heavily on CSF volume.
They'll ask about pharmacology.
Absolutely. Compare and contrast the main LAs bupivacaine versus lidocaine versus ropivacaine. Detail the mechanisms and risks of hydrophilic versus lipophilic adjuvants.
And complications.
You have to give that structured discussion. Cause, mechanism, prevention, management for hypotension, PDPH, and a high spinal. And expect scenario-based questions on special situations, like dose modifications for an obstetric or elderly patient.
What are the best concepts for focused short notes?
PDPH, differential blockade, transient neurological symptoms, and its differentiation from cauda-equina syndrome, and the management of a failed spinal.
All right, time for the quickfire Viva round. Model answers only. Question 1. How do you assess motor block resolution postoperatively?
Answer: use the Bromwich scale. 0 is free movement, 3 is a total block. You must ensure the patient is Bromwich 0 or 1 before ambulation.
Which is the most sensitive nerve fiber type to local anesthetics, and why?
Answer: the small myelinated B fibers, the preganglionic sympathetics, because of their smaller diameter and reduced external protection.
If a patient develops a high spinal, what is the single most important physiological loss causing the immediate crisis?
Answer: blockade of the T1 to T4 cardiac accelerator fibers, resulting in unopposed vagal tone, severe bradycardia, and a profound loss of cardiac output.
What is a primary safety concern with intrathecal morphine?
Answer: delayed respiratory depression, which necessitates extended postoperative monitoring for 18 to 24 hours.
Finally, let's give them that ultimate single-page summary, the facts you internalized for the last 15 minutes of revision.
Okay. Anatomy. Cord ends L1, L2 in adults. Dura ends S2. Tuffier's line is L4, layers. Skin: supraspinous, interspinous, ligamentum flavum, dura, subarachnoid. Sympathectomy from T5L1 causes pooling and decreased cardiac output. Bradycardia if T1-T4 is blocked. Block progression. Sympathetic B fibers are most sensitive, then sensory, then motor.
Pharmacology.
Bupivacaine is long-acting and cardiotoxic, fast in, slow out. Lidocaine has a high TNS risk. Baricity is the key control for spread. Morphine is hydrophilic with a delayed risk. Fentanyl is lipophilic and short-acting.
Spread.
Spread is inversely proportional to CSF volume. That is the single most important factor. High intra-abdominal pressure from pregnancy or ascites or just old age increases spread and means you must reduce the dose.
And finally, complications.
Hypotension and bradycardia management requires aggressive vasopressors. PDPH requires pencil point needles for prevention and an epidural blood patch for treatment. You avoid TNS by skipping high-dose lidocaine. And strict coagulopathy screening is essential for preventing a hematoma.
That systematic review is exactly what's needed to build confidence. The integration of cause and effect is key, knowing that a T1-T4 block leads to bradycardia, which then informs your choice of vasopressor.
Remember that every time you perform this block, you are intervening in a delicate fluid system and a complex physiological chain. Your understanding of anatomy dictates safe entry, your grasp of pharmacology dictates spread, and your knowledge of physiology dictates your crisis response.
Absolutely. And as you apply this knowledge in the operating theater, let's close with a final clinical challenge. Given that CSF volume is the dominant factor determining spread, and we know this volume is unpredictable in obese or pregnant patients, how does the emerging utility of pre-procedural ultrasound guidance, used not just to find the midline, but to potentially estimate the depth, maybe even the density of the CSF space, suggest a future where spinal anesthesia dosing becomes highly individualized, moving beyond standard formulas? It demands that, even with new technology, we never forget the fundamentals. Meticulous aseptic technique, appropriate needle choice, and diligent coagulopathy screening remain the absolute bedrock of safety.
A fascinating path forward for the specialty. Study hard, integrate this material, and trust your structured preparation.
That's it for this deep dive. We hope this preparation has been thorough and clinically focused. We'll see you next time.